Good morning, everyone. Happy Veterans Day to everyone, especially those who have served or have family members that have served. Today we have Journal Club. We have two presentations. Our first presentation is going to be Dr. Paterniti, who is going to talk to us about outpatient cervical Foley for cervical ripening and induction. And Dr. Taylor Jones is going to do the second presentation, and she is going to talk about using candy cane stirrups versus boot stirrups in vaginal surgery. So I would like to go ahead and turn this over to Dr. Paterniti for his presentation, and then we'll do question and answer afterwards. Thank you.
Okay, good morning, everyone. Let me share my screen and get that loaded up. Is everyone able to see my screen?
Yes.
Okay.
Yes.
All right. So the paper that I chose to do is this. It's a randomized control trial, outpatient Foley catheter for induction of labor in nulliparous women. It was published in the Green Journal and is one of the papers in their series of Journal Club articles that are suggested. So a background on this issue. 20 to 25% of pregnant women now undergo labor induction, and many of those, especially nulliparous women, require cervical ripening. The ARRIVE trial has contributed to increased number of elective inductions of labor. Previous studies have shown that elective induction of labor is associated with a 6-hour increased length of stay on labor and delivery. So based on these findings, the authors were interested in a potential method of cervical ripening at home. They chose mechanical methods because those are associated with lower rates of uterine tachysystole and meconium-stained amniotic fluid. Their essential research question was, could cervical ripening at home result in shorter stays on labor and delivery and happier patients without any increase in maternal and fetal adverse outcomes? And their formal study objective was to see whether outpatient cervical ripening with this Foley catheter in nulliparous women who were undergoing elective induction of labor shortens time from admission to delivery. The study type is a randomized control trial, actually a fairly large randomized control trial for this type of study. The primary outcome was time from hospital admission to delivery. There were many secondary outcomes. Some were related to maternal health and peripartum outcomes, such as infection, cesarean delivery, the total hospital length of stay, whether there were unscheduled hospital admissions or OB triage visits. There was also a component that looked at maternal satisfaction, and they did that with 3 different surveys that they gave each patient. And then there were some pretty standard fetal outcomes that were looked at: 5-minute APGAR score less than 7, cord gas, pH less than 7.1, base deficit greater than 12, and NICU admission. The inclusion criteria was that the women had to be nulliparous, at least 18 years old. They had to have a singleton pregnancy in cephalic position. They had to be between 39 and 0 and 41 and 6 weeks gestational age. They had to be undergoing elective induction of labor. Of course, they had to live close enough to the hospital and have reliable phone access. They performed a modified Bishop score, which was simply the components of the Bishop score that you would get in a normal cervical check: dilation, effacement, and station. And they had to have that score less than 5 and a maximum cervical dilation of 2. Exclusion criteria included any kind of fetal anomaly, including fetal death, fetal growth restriction, suspected macrosomia, or a BPP of less than 6, any kind of amniotic fluid abnormalities. Most hypertensive disease, they defined uncontrolled chronic hypertension as chronic hypertension requiring 2 or more medicines. So if it did not meet that criteria, that person was eligible, but otherwise they excluded people with hypertension in pregnancy. Uncontrolled pregestational diabetes or white class C or higher, hepatitis B, C, HIV, and then some miscellaneous things like if they had a latex allergy or for some reason they were ineligible for a vaginal delivery. So the method of the study, eligible women were called at 37 weeks to introduce the study. Women who wanted to participate presented at 39 weeks. A BPP, a blood pressure check, and a cervical exam were performed in a clinic visit to confirm their eligibility, and then randomization was performed by computer in a one-to-one fashion. Women who were randomized to outpatient Foley had their cervix prepped with betadine, then they had a 16 French Foley catheter placed and 30 cc's of sterile water injected. This Foley was then placed under tension and taped to their leg. Following Foley placement, they were observed for 20 minutes with fetal monitoring and tochometry. If they had rupture of membranes during the process, vaginal bleeding, or non-reassuring fetal heart tones, they were admitted to labor and delivery. Otherwise, they were discharged with labor precautions, bleeding precautions, and sent home and told they could take Tylenol for discomfort while they were home. And then they were to present the following day for induction of labor. They were also told that if the Foley bulb came out while they were at home, they could stay home as long as nothing else concerning was happening. Women who were randomized to the inpatient Foley were simply discharged following the visit and told to return the next day. When they arrived, they were treated just like any other induction. A cervical exam was performed to see if they still needed cervical ripening. A Foley was placed and oxytocin was started at the same time. For both groups, the Foley could remain in for up to 24 hours after placement, and failed induction was not diagnosed until they were 18 hours ruptured on oxytocin. So here are the main results of the study. You can see for the primary outcome, there was a difference in 4.3 hours between the outpatient and inpatient group. That's a difference in time from admission to delivery, and that was a statistically significant result. Secondary outcomes, so as expected, delivery within 24 hours of admission was greater in the outpatient than the inpatient group. But notably, total hospital lengths of stay did not change between the groups. There was a significant increase in unscheduled hospital admission with patients coming to OB triage in the outpatient cervical ripening group. There was an increased rate of phone calls to OB triage and an increased rate of Tylenol use in those patients as well. There was no difference in spontaneous rupture of membranes. There was really no difference in any of the fetal measures between the groups. So to look at this study critically, first we ask, so what is the significance of this study for us specifically? We do perform a significant amount of elective inductions of labor. We are a low volume, I would say high acuity center, and we only really struggle with volume anecdotally about 10 to 20% of the time. Often, in my experience, there's a minimum of labor and delivery nurses that remain, in-house and ready, even if they don't have patients assigned to them, because patients, of course, come in overnight unexpectedly. Cost is always important. As I say on the next slide, this is essentially a cost and satisfaction study because it's not really powered to look at safety. But one question that comes to mind for me as I read the study is whose money is the study saving? Is it saving money for the patient, the hospital? Is it saving money for Medicaid? It seems like at the end of the day, it's saving money for Medicaid. I believe the research question is pretty clear. As I said, this is essentially a cost analysis and a satisfaction study. Is it cheaper to do this, and are women happier? The hypothesis is implied. The authors clearly believe that outpatient cervical ripening will result in significant cost savings and improved maternal satisfaction with no increase in negative fetal outcomes. Even by the author's admission, the direction of the primary outcome was expected. That is, if you start cervical ripening at home, you expect there to be less time from admission to delivery. What they were really investigating, I believe, is the time and whether that time reached some measure of significance, which we'll talk about, that they determined. This is a randomized controlled trial. They did do an a priori decision regarding what was considered a clinically significant primary outcome, which was 5 hours, greater than 5 hours difference between the patients who underwent inpatient and outpatient cervical ripening, greater than 5 hours from admission to delivery difference. They also performed an a priori power calculation of the sample size that was needed to show that difference, which was 126 patients. I believe these are significant strengths of this study. It was a well-done study. The protocol is different for inpatient versus outpatient groups. You might have noticed that outpatient groups receive a Foley catheter, and then when they arrive at the hospital, if it's still in place, then they're started on oxytocin. The inpatient group was given Foley catheter plus oxytocin right from the outset. You could consider this a downside of this study, or you could consider it a strength of the study. The strength of the study is that it's generalizable to actual practice because it's more realistic to what we would actually do, even though it's not exactly the same for each arm. I wanted to look at the study population. Study population, you can see, was 73% Black, 14% Hispanic, 13% white. You can see the U.S. Demographics, and then you can see the demographics of our patient population. This was a patient population that was significantly different from the U.S. population, but not as dramatically different from our population. 100% of the study population had public insurance. My one question that came to mind was, what are the racial demographics of the entire eligible cohort? And is the study population representative of the cohort? That is to say, were Black patients more likely to enroll in this study than white patients or Hispanic patients? And then another question that came to mind, also probably based on my anecdotal experiences, is there any kind of racial or cultural difference in attitudes towards cervical ripening with Foley catheter? Are some, not necessarily even races, but just in different areas, is there a cultural, opposition to this or more acceptance of this in different areas using Foley catheter for cervical ripening? Overall, I would say the inclusion and exclusion criteria seemed appropriate. For the primary outcome of time from hospital admission to delivery, 5 hours was considered clinically significant. They performed a power calculation based on a power of 0.8, and they used a two-sided alpha of 0.05, even though they expected the difference to be they expected it to be less time and not more, but still that's pretty standard. It was impossible to blind the study to the investigators following randomization, and so to compensate for that, the authors chose an objective primary outcome that was less susceptible to bias. So to discuss the results, here are the key results from my perspective. There was a 4.3-hour reduction in time from hospital admission to delivery in an outpatient cervical ripening group. There was no difference in total hospital length of stay between the groups. There was a significant increase in unplanned hospital admissions in the outpatient cervical ripening group. There was no significant difference in maternal or fetal outcomes, although, as I said, the study was not really powered to detect these. And there was no significant differences in maternal satisfaction between the groups. As I read the study, one question came to mind, which is this a negative results study? In other words, is this a study demonstrating that the null hypothesis is true? The authors seem encouraged by the results, but I suspect the difference in time is much less than they expected. Other similar studies have been performed with a difference from admission to delivery of closer to 9 hours. So they may even have thought that the assignment of 5 hours as a clinically significant number was on the more conservative end, but it was less than that even. By definition, the difference fell short of their a priori determination of a clinically significant difference. Maternal satisfaction was the same in each group. And I looked up some other cost studies. A study that was published in the American Journal of Perinatology showed that outpatient cervical ripening was no longer cost saving if less than 3.5 hours were saved on labor and delivery. The difference in this study was 4.3 hours, which is only slightly longer than that benchmark. Some other questions that came to mind related to cost. What is the cost of these 11 additional unplanned admissions via OB triage visits? These are emergency room visits. What is the cost of every single one of those patients coming to clinic for an additional visit? I guess each visit didn't last 30 to 45 minutes. Only half of them did if the patient was enrolled in the study, but this is still a significant labor requirement to do each of these visits. Ultimately, there's pretty good data beyond this study that outpatient cervical ripening with Foley catheter is safe and feasible. My question was, if patient satisfaction and total length of stay are unchanged, is this difference of 4.3 hours of time on labor and delivery significant enough to warrant a practice change? Other considerations that I had, other studies that have looked at somewhat similar designs looked at how well patients were able to sleep at home versus inpatient, which I thought was interesting. I was also curious if there was any difference in rates of venous thromboembolism between the groups. If you look at one of the secondary outcomes, the duration of neuraxial anesthesia use was almost identical to the difference in admission time on labor and delivery. So essentially the outpatient induction group used Tylenol for 4 hours, whereas the inpatient group used 4 hours more of neuraxial anesthesia. So the question would be, does this additional period of immobilization have any impact on VTE rates? And then I would also be interested in seeing the total time from induction to delivery, which other studies have reported, but this particular one did not. And then these are, the first one is the study, and the second one is the cost analysis that I looked up. So that's it. And now I'm open to any questions.
Do we have any questions for Thomas?
Yes.
Dr. DeVoe?
Well, your presentation, Thomas, was absolutely excellent, spot on, and that's the way they should all be. It's looking into the study beyond what the study actually was about. My concern about a study like this is the fact that the conclusion that there was going to be shorter time was preordained. So, I think they're just proving the obvious. And I guess the question, there are other mechanical means of ripening the cervix, such as artificial laminaria, which some studies have been shown to be one of the best mechanical ways of doing cervical ripening. And I'm wondering why they didn't consider a group which that was the mechanism used for cervical ripening. But I think the question, these cost-saving studies, they're very difficult to do because costs are determined differently in different obstetric units. And when you look at this, is this going to change practice in our institution? No. Is it going to change practice anywhere else? Probably not. So the main benefit that I get from this study is it showed that while you do this, it's not going to be the way of the future. The other thing that isn't indicated in this study is when you look at mean birth weights of babies and delivery outcomes, that's kind of a poor measure of looking at who really was at risk for cesarean section based on cephalopelvic disproportion. And they don't have that. That's not drilled down into this study. But that would have been something very good for them to actually look at. And so I think what this study does, and I think you're right, Thomas, prospectively, it says, okay, it can be done. We did it, but we don't think there's enough evidence to make this a practice change.
I agree with you.
I think the study is interesting in the regards that the ARRIVE trial does point towards, 39-week induction. I think you're going to see a lot more of an increase in inductions. We've already seen it since the start of the ARRIVE trial, and it's been documented in other research studies. And I think at some point there is going to have to be greater interest in outpatient cervical ripening because of everything that's going to go on with an increase in inductions. We aren't building more labor and delivery units. And even if you save 4 hours, 5 hours of labor and delivery time, cost savings aside, that also allows for greater throughput on very busy labor and deliveries. So I think it's an interesting study. Will it change our practice? Probably not. What I did also find interesting is in our institution, it seems like almost nobody can get a Foley unless they have an epidural catheter placed first, whereas in UAB, patients are taking Tylenol with a Foley catheter in place. So to me, that's a rather different. And where I came from in Detroit, we oftentimes place cervical Foleys without patients having neuraxial analgesia. So that to me was one of the most interesting things is at our institution, it seems like neuraxial analgesia is a must prior to Foley placement. And that oftentimes delays Foley placement for several hours if we're very busy in order for patients to get neuraxial analgesia.
Dr. Jane?
Yes.
What do you think about the fact that they only put 30 cc's in the Foley? Typically, we would put significantly more, like closer to 50 or 60 cc's.
Yeah, I mean, I think you don't necessarily, get more for your buck, but I don't know. I mean, I would have to see a study that compared varying amounts. But I would say, at 30 cc's, they were able to ripen the cervix, and when they added oxytocin, it seems like their Foleys fell out pretty quickly in 4 or 5 hours in the hospitalized group. So they seemed to achieve what they needed to. It would be interesting to see if there are studies out there that look at varying amounts in the cervical Foley and see if that leads to faster delivery, and also if there's more, uterine tachysystole, or if there's more, fetal bradycardias or heart rate abnormalities.
Sure, yeah. And I guess I was trying to kind of drill down and focus on the relevance for us as kind of a lower volume center, but I can't imagine in like Orlando, where I came from, or like Parkland and Dallas, a place that has, 14,000 deliveries a year, 4 or 5 hours less on labor and delivery might actually be significant for them.
Do we have other questions for Dr. Paterniti? All right, well, thank you, Thomas, for that excellent presentation, and we will move on to Dr. Jones, who will be talking to us about vaginal surgery and the use of boot stirrups versus candy cane stirrups.
Thank you, Dr. Jane. I'm going to share my slides here. I think everybody can see and hear me. So I did the candy cane compared with boot stirrups and vaginal surgery, a randomized control trial that was in the October Green Journal. So for background, incorrect intraoperative patient positioning can lead to both short-term and long-term injuries. Iatrogenic neuropathy is largely unrecognized and is reported to occur 1.1 to 1.9% of all GYN cases. These injuries could include joint dislocations, plexus injuries, pressure ulcers, and nerve injuries. Nerve injuries to include ilioinguinal, iliohypogastric, femoral, lateral femoral cutaneous, just to name a few. The risk factors that would increase this nerve damage would include the patient's age, the type of surgery, operating time, the patient's BMI, and obviously inappropriate positioning. Injury can be minimized by avoiding excessive hip flexion or abduction and direct pressure of the perineal neck, leg contact with support rods, and any positions that do not align the thigh, knee, and heel to the contralateral side. The primary objective of this study was to compare the participant positioning during vaginal surgery in boot stirrups versus candy cane stirrups and its effect on the PROMIS physical function domain, which is a patient-reported outcomes measurement information system. The study design was a single-center randomized control trial conducted in the urogynecology department at the University of Louisville. The participants were asked to assess their baseline pain using a 100-point visual analog scale, and that visual analog scale scoring included pain from the lower back, the hips, the buttocks, the thigh, the knee, the calves, and the feet. The participants completed this PROMIS physical function score, which also included pain intensity, pain interference, and pelvic floor disability index. Women that were considered for this study included women who were only undergoing vaginal surgery. There couldn't be a change to abdominal or to laparoscopic surgery. The patient could not be repositioned during surgery. The exclusion criteria included patients who were wheelchair bound or immobile, those with pre-existing neurological conditions, and those that complained of at their pre-op visit that they couldn't tolerate a high lithotomy position for a long time. The study design was a randomized 1-to-1 cane stirrups versus boot stirrups. The patient was positioned by the attending surgeon, and then angles of the hip and knee joint were measured by the goniometer, which measures the fulcrum, where the fulcrum was placed at the anal opening, and then they measured the angle between the femurs. On post-op day 1 and 6 weeks post-op, they took the same surveys that they filled out initially to, again, assess the physical function, pain intensity, and pain interference. Adverse events were documented at both the post-op day 1 and 6 weeks post-op visit. So their primary outcome was just to determine, was there a change in this physical function form, and this was all self-reported. The PROMIS assessment tool was developed by NIH. It's just a free available tool that measures basically functional outcomes, and it's based off the patient's ability to perform basic and instrumental activities of daily living. It has been validated and demonstrated response to interventions amongst diverse clinical populations. So the study design, the patients were assessed from March 2018 to October of 2019. There were 141 patients that were randomized, and a total of 9 patients were removed from the study for surgeon preference or loss to follow-up or intraoperative position changes. Ultimately, 68 patients underwent the candy cane stirrups group, and 64 patients had boot stirrups during their vaginal surgery. As far as patient composition, there was no statistical difference between the candy cane group or the boot stirrup group. Patients were ultimately between their 40s and the 60s years old. They were mostly overweight to obesity class 1. Several people actually had previous joint replacements. Patients underwent vaginal hysterectomy, vaginal vault suspension, vaginectomy, slings, and other diverticulectomies or fistula repair or mesh excision. The duration of the surgery was quoted to be 1 hour and 45 minutes plus or minus an hour. And then adverse events were also noted, and this just included changes from routine post-op care to include non-routine medications such as radiological interventions, return to the OR, and general anesthesia with general anesthesia. So the results, the angle of the flexion of the hips and the knees were thought to be similar in both groups. However, there was a significant difference between the angle between the femurs, which the candy cane group had a larger angle than the boot stirrup group. There were no difference in pain of the lower back, the buttocks, the hips, the thigh, the knees, the calves, or the feet in post-op day 1 after the procedure. There were two participants who did report neurological injury on postoperative period. One person in the candy gang group said that they had femoral or was diagnosed with femoral neuropathy, but it did resolve spontaneously. And in the boot stirrups group, that patient reported unilateral foot numbness in the perineal nerve distribution and persistent at 6 weeks. Neither, when you look through the study, they did not point out which procedure that both of these patients had done, and they did not point out how long the actual procedure lasted. So there was a significant difference between the physical function between both groups at the 6-week visit, with the boot stirrups group having better function after the procedure. And the way they were able to tell this is they used the physical function score as being 50 as the set number for the mean general U.S. population for their physical fitness. So if you had points above 50, then you were noted to be better performing than the U.S. population. And then if you perform less than that, then you were thought to have less physical function. They actually determined 2 as this clinical significance. So if you scored less than 48, you were thought to be less functional. They didn't note in the study why they chose 2 as their clinically significant number, but that's thought to, we could talk more about that basically. Those randomized to boot stirrups reported improved physical function after 6 weeks after the surgery. And although pain intensity improved with the boot stirrups groups, there were no other differences in pain intensity or interference between the groups. They did perform a linear regression model that fit to predict the PROMIS scores and took out the confounding factors of age, BMI, and comorbidities in the duration and surgery, and found that the change of PROMIS scores favored boot stirrups overall. And there were no changes in pain intensity and change in pain preference, pain interference. So in their discussion, they noted that women randomized to the boot stirrup positioning group had better physical function outcomes at 6 weeks. Overall, neurological injuries after GYN surgeries are rare and usually present with sensory deficits that resolve within 7 days. Their study of 0.4% injury, which is similar to the existing literature. Due to the power of the study, they were unable to show that candy cane stirrups caused more neuropathy than boot stirrups. They would have needed approximately 3,800 patients to adequately assess this difference. So they were kind of limited in their power. So they were limited in making larger conclusions. Worsening pelvic floor symptoms are associated with worsening physical function scores, and although there was significant improvement in the pelvic floor symptoms in both groups, only the participants in the boot stirrups groups reported an improvement in physical function. And then guidelines for dorsal lithotomy positionings recommend preventing overflexion at the hip and knee and recommended limiting abduction at the hip. And we noted, or they noted, that there was the angle between the femur was noted to be greater in the candy cane stirrups than it was in the boot stirrups. So discussion as far as the study strengths and limitations. The study was appropriately powered for what they wanted as their primary outcome, which was basically patient satisfaction and patient report of their physical well-being at 6 weeks visit. It was randomized appropriately. It was a 1-to-1 group assessment, and then it was single masked. Over in the limitations column, I do have that you're unable to mask the operating surgeon is what that should say, because it's just hard to determine or hard to blind the surgeon to the patient being in cane stirrups versus boot stirrups. Like I said, the patient reported outcome is basically their primary outcome. However, they were able to involve both objective data of the hip and the knee angles, which I think does boost their study, but I don't think it adds anything in addition to that. They were able to correct for things such as BMI and the duration of their study. As far as their limitations, they did only do a follow-up 6 weeks out. It would have been nice to know how those 2 patients did that had the neuropathies, what they were doing both at 3 months and 12 months. And then physical function is a general measure of physical well-being, but it's not directly correlated to neurological injury in this population. And then this says a similar thing, that the boot stirrups did have better physical function outcomes. So for further investigation, does this patient composition match our patient population at Augusta University? And for the most part, it does match our population. The only thing that I would add is that a lot of our patients tend to be higher obesity than the average, and their average was just obesity and obese class 1, whereas we tend to have patients that have a higher BMI. Should this be implemented broadly for all GYN surgeries? Ultimately, the surgery that they did was an hour and 45 minutes plus or minus 60 minutes. So that's ultimately a surgery that could last 45 minutes. So if you're thinking about doing a minor procedure like a hysteroscopy, DNC, a polypectomy, or an operative hysteroscopy, that may not take as long and may be between 30 and 45 minutes. So we could consider using Allen stirrups or boot stirrups across the board. By the time you set up the patient, prep and drape, do your procedure, and then clean the patient, it's probably most likely going to be around that same 30 to 45 minute range, which is what they used as their surgery. Again, the outcomes could be extended a little longer with the patients that they used. Again, it stopped at 6 weeks, but how are they doing it 3 months and 12 months? And I think this was maybe done because most of the patients at that point reported that they were doing fine and their physical function was back to normal. But it would be nice to see what would happen if they extended the presentation or extended the research project longer. Also to note, there was multiple patients, 20 patients who had previous joint replacements prior to this procedure. They did not say whether it was a hip replacement or a knee replacement, or if it just was a shoulder replacement, that which may be unrelated to the surgery. So the only positive thing is that they did have pain scores before the procedure, and then both post-op date and 1 in 6 weeks. It would be nice to know if there would have made a difference if we would have taken all of the patients out that had previous joint replacements, or if that even mattered. Again, it was difficult to assess power with a small group of patients for neuropathy, so they weren't able to determine that. And then again, the effect on BMI as a physical function after the procedure, it would be nice if they had a larger range of BMI. And then I just did a little bit on proper positioning, and that the angle should be 90 degrees at the knees and at the hips. There was not a study. There was actually just like a commentary that I read on an anesthesia blog. So this didn't actually have any research study attached to it, but it did say that there was a 100-fold increase in injury risk per hour spent in a lithotomy. And currently, there's a decrease in incidence in neuropathies associated with vaginal surgery because physicians are aware and they perform proper surgical positioning. And those are my references.
Thank you, Taylor. Do we have questions for Dr. Jones?
Taylor, were the patients themselves actually blinded to which type of stirrups they got?
Sorry, yes, Dr. Paterniti, they were blinded, so they didn't know what they had, which is a positive for the study and the results that came from it.
Gotcha. Okay.
Dr. DeVoe?
Yeah, one of the problems that I found with this study is when you're looking at a patient's subjective assessment of physical function, that's not the same as putting a patient through a physical function test. And that's a question that persists in every single study where self-reporting is used. And that you could consider that as a weakness just in terms of maybe a bias. But there's another issue here as well, and that is looking at physical function before and after as a function of patient age. And I didn't see that done in this study, and maybe it was because the study was small. They wouldn't have large enough groups in each age decile to assess that. But I think that's an important point that we don't get out of this study. That is, is physical function, is decline in physical function after surgery an age-related thing? And one could say the same thing with BMI as well, because that's another important variable in looking at physical function. So those are two things that would have been nice takeaways from this study had they been looked at.
I'll take a little bit of a counterpoint on that, Dr. DeVoe, in the regards to them using physical, self-reported physical functioning. Obviously not objective, very subjective based on the patient's, but in retrospect, maybe that's the more important measure, is if the patient feels they're more active than rather if we objectively measure. If a patient feels better, even if we can't objectively measure that they are better, maybe it's still very important that the patient actually feels better. So you can also take that counterpoint on that. But I agree, in terms of the study, as Dr. Jones pointed out, looking at neuropathy itself requires 1,000 patients to be randomized. So I don't think you're ever going to see a study that could look at neuropathy because it is such a rare incidence. But whether this is a good enough of a substituting factor is hard to say. I will say that, at least in my practice, I tend to use boot stirrups for almost all of my vaginal surgery. That's especially anything that's anticipated to be a longer procedure, mostly because of patient comfort, but secondly, it gives me more options in case the surgery doesn't go as planned and I need to convert to adding a laparoscope or anything like that. I can then place the patient in low lithotomy position without any difficulty. And I think that's one of the many benefits of using boot stirrups, is the ability to make changes without having to put the patient into a different stirrup or anything like that. Do we have other questions for Dr. Jones or comments? All right. Well, I'd like to thank both Dr. Paterniti and Dr. Jones for their excellent analysis of these articles. And, I think we're going to be done for